Okay, so this is a lecture on calcium, specifically the diagnostic pathway and what to do if you get a basic metabolic panel back and it shows a high or a low calcium. So this lecture is not all-inclusive for all the possible causes of abnormal calcium, but it does go through the most common issues encountered by an internist on a daily basis. It also doesn't cover treatment, but for that you can watch the full video from which this lecture was adapted on the online MedEd website. So calcium is often the long-lost electrolyte, along with maybe chloride. And the reason it's often forgotten is because most of the time when you get a BMP back and the EMR says that there's an arrow pointing up or down, it's usually nothing to worry about. So the first thing that you should do whenever you see a calcium that's high or low is to check the albumin. Why? That's because calcium travels in the blood bound to albumin. So for every 1 point change in albumin level, there's about a 0.8 point change in the calcium that's displayed on the BMP. However, this doesn't really change the real levels of calcium in the blood because, as you can see in this graphic, even as the total calcium changes with the amount of albumin, the calcium that's not bound to the albumin, or the ionized calcium, is the only one that really matters. So once you check the albumin, the next thing that you would do is recheck a BMP if the calcium is still abnormal. You might want to consider also ordering an ionized calcium at this point. A lot of times, an abnormal calcium can just be a lab error. So, if the corrected calcium after you corrected for albumin is normal, or the rechecked calcium or ionized calcium is normal, you don't have to worry about it. You're done. You can forget about the BMP showing that low calcium or high calcium. So if the calcium is still abnormal, that's when you have to take a closer look. And really, there's three main possibilities when you have an abnormal calcium. It's either low, elevated, or significantly elevated. If it's low, this is synonymous with hypoparathyroidism. When you see hypoparathyroidism, think post-op, post-op, post-op. Either it's a temporary depression of the calcium from any surgery where the parathyroid gland sort of gets stunned and there's going to be a normalization of the calcium within a couple days to weeks, or it's a thyroidectomy where the parathyroids might get accidentally removed or damaged, resulting in a more prolonged hypoparathyroidism that may or may not resolve over the course of months. Or it could be permanent post op damage to the parathyroid gland itself, where it's never coming back, it's permanently damaged. So, there are also some autoimmune conditions that can cause hypoparathyroidism, but they're more rare. And if the patient is not post op and has true hypocalcemia, just check up to date for what to do next for an autoimmune hypoparathyroidism. All right, so that's hypocalcemia. Next, we'll look at hypercalcemia. When you see a mild to moderately elevated calcium, you're going to want to order a PTH level, a phosphorus level, and a 25 vitamin D level. That's 25 vitamin D, not 125 vitamin D or calcitriol. And this is because 125 vitamin D levels in the blood are too variable, and because of this have a limited diagnostic utility, and 25 vitamin D is a reasonable proxy, so we just order that. So before we go over what the lab values mean, let's first take a look at how all these things interact. So for that, I'll just pull up a whiteboard here, and here's our guy, and he has his bow tie, that's his thyroid, and if you recall, the thyroid has these small glands attached to it, those are the parathyroids. And these parathyroids have calcium sensing receptors on them, so when there's low calcium, they sense it, and they release PTH. That PTH goes into the blood and acts mainly on bone and the kidneys. So in the bone, it activates osteoclasts, which release calcium and phosphorus from the bone. And in the kidney, it leads to increased reabsorption of calcium, but cause decreased reabsorption of phosphorus. Then it also tells the kidney to increase its activation of vitamin D, which then goes to the gut and causes increased reabsorption of both calcium and phosphorus. But here, really, the most important part of it is what happens in the kidney. So the kidney dominates over the bone and the gut. Whatever's happening in the kidney ends up influencing the levels of calcium and phosphorus most in the blood. So, with that in mind, what does it mean then if you have a high PTH, a low phos, and a high or usually normal vitamin D? It means the kidney's still working and still making vitamin D, so the cause of the hypercalcemia is primary hyperparathyroidism. Primary hyperparathyroidism. This means that the problem is in the parathyroid itself, and 8 out of 10 times it's going to be a parathyroid adenoma, but it can also be parathyroid hyperplasia or carcinoma, and in this case you would just consult endocrinology. Okay, so what if instead you have a low vitamin D? That means that the cause of hypercalcemia is secondary hyperparathyroidism. Secondary hyperparathyroidism is usually from chronic kidney disease because the kidney isn't activating the vitamin D. but it could also just be from a lack of vitamin D or vitamin D deficiency, and also just low calcium intake. These could be seen in, for example, a patient with malnourishment or failure to thrive. Okay, so that does it for hypercalcemia. Now, what if you have severe hypercalcemia, meaning the calcium values are in the 14s and above? This should be really concerning to you because most often it's a sign of some sort of malignancy. So, if you see a calcium near 14, the next thing you should do is order a PTH, FOS, and PTH-RP. If the PTH is low and the PTH-RP is elevated, that points to a malignancy of the lung secreting ectopic PTH as PTH-RP. Further workup can then be done with a chest x-ray and more advanced imaging of the lung after that, but that's more out of the scope of this lecture. So if the PTH is low and the PTH-RP is absent, then it raises a suspicion for a malignancy involving the bone, such as metastatic breast or prostate cancer or multiple myeloma. You can look for other clues on the CBC for this multiple myeloma, or you might need to pursue a bone marrow biopsy, but again, that's out of the scope for this lecture. So just to recap everything we talked about, when you see an abnormal calcium on the BMP, usually it's nothing to worry about. First, check the albumin, then repeat the lab test. If it's still abnormal, take a closer look at whether the calcium is low, elevated, or significantly elevated. Low calcium is usually seen post-op and will normalize with time. If you have elevated calcium, check a PTH, FOS, and 25 vitamin D level. If the vitamin D is high or normal, it's primary hyperparathyroidism. If vitamin D is low, it's secondary hyperparathyroidism. If the calcium is significantly elevated, you probably have a malignancy. Check a PTH, FOS, and PTH-RP. If the PTH-RP is high, look for lesions in the lungs. If the PTH-RP is absent, look for lesions in the bone. And that's it for this calcium lecture. Thank you.